This is May the 17th, and you are joining Barb Clark, our presenter today, about fetal alcohol syndrome. And we want to make certain that if you are needing Spanish interpretation, that you go to the bottom of your toolbox. And if you hover where it says interpretation, then you have the option between English and Spanish. So if you need Spanish interpretation, that's where you go. And we are going to go ahead and get started, and welcome everybody, and welcome Miss Barbara for joining us. And yeah.
Okay. Yeah, thanks for having me. Okay, so I am not in Catalina Island. I'm just pretending, trying to be there. My name is Barb Clark. I work at NACAC, our lovely sounding acronym. That is the North American Council on Adoptable Children. We are located in St. Paul, Minnesota, but we work all around the US and Canada doing advocacy and training and support and stuff like that for around adoption, foster care, and kinship relative care as well. I myself am an adoptive parent, so I'm going to be sharing some stories of lived experience today. And I have a daughter who is, my kids are all young adults now. I have an 18, 19, 20, and 21-year-old. And my 21-year-old has a fetal alcohol spectrum disorder. And prior to this career that I have now, I used to work with at-risk teenagers. And boy, I wish I knew what I know now about neurodiversity and brain differences and all that kind of stuff, because it would have made a huge difference in my decades of working with young people. But now I'm just passionate about getting the right training and information out about fetal alcohol spectrum disorders, because what I learned was that there's a lot of misinformation, old information, outdated information, and still just not enough emphasis put on this disability and the impact that it's having on many of our children, adolescents, and families. So super excited to be with you guys today. If you have questions, feel free to, you can put them in the chat box, and the different staff who are going to be helping and interrupting me and asking a question if you have one, or you can save it till the end. We're doing two parts here today. We'll have a break afterwards, but I'm just going to start sharing my screen and getting to work here talking about this. So let's see here, I'm going to have to readjust this. I should have practiced this. I just did a different training and I had to use Google Slides for it, so it's a little bit wonky. So one of the things that we're trying to do with fetal alcohol spectrum disorders is we're trying to frame it within a trauma lens nowadays. And because it is trauma, fetal alcohol spectrum disorders is trauma. So Dr. Bruce Perry, who's the big shot, most well-known expert on childhood trauma, he kind of puts trauma into three categories. So he talks about intrauterine insult as the first type of trauma that some of our kids can experience. So that could be exposure to prenatal exposure to drugs or alcohol. But it also could be if a woman is just super highly stressed consistently throughout her pregnancy, right? Any pregnant woman is going to be stressed and have stress. But if it's toxic, chronic stress throughout the pregnancy, we know that when we're stressed, we have cortisol going through our body, and that can have a significant impact on a fetus as well. But the alcohol and drugs are kind of one of the most common in utero traumas that our kids can experience. Then we also have the second kind of category, the way he lumps it, is kind of early neglect and or separation even. That in and of itself is a type of trauma. So we know we know that through a lot of research how important those early years are to the developing brain for an infant, right? There's a lot of research out there that has shown that. We know that infants need that kind of the serve and return is what they call it in the early childhood, world, like where when an infant cries, a parent or a caregiver comes, figures out what's going on. Are they hungry? Are they dirty? Are they wet? Are they in pain? What's going on? Discomfort. And we try to relieve that. And so, that often is not, too many of our kids are not getting that attention that they need for their brains to develop healthy in those beginning years. Could be a lot of different reasons for that. It could be a family where there's domestic violence. It could be a child who's in an orphanage. Usually that would be in a different country. We don't really have too many orphanage kind of places left anymore in the US, but It could be a birth mom mom who's struggling with postpartum depression or other mental health stuff. Lots of different things of why that could be. It could be cognitive abilities, could be addiction. All these different things might be happening that infant isn't getting the right attention. I just heard a story a couple of weeks ago. I was doing a training for a different state, and a woman started typing in that she had just been in Haiti 2 weeks prior to that, and in an orphanage. Because I always hear stories from a lot of the Russian orphanages or Ukraine or Kazakhstan, how parents have told me that when they go in there into the infant room, there could be dozens and dozens of cribs full of babies, and none of them are crying. And it's just kind of eerily silent. And that is not good, right? That's a sign that those infants learn to just stop crying because nobody came. And that really stunts and impacts their brain development. So we know that that's crucial in those early years, and sometimes our kids aren't getting it. But also just a child who, even if it's immediately after birth, is not with the biological family and is either put into a foster home or an adoptive or kinship kind of placement, that in and of itself can be very traumatic for a brand new infant, or at any stage in their life in those early years. So that's a second kind of category of trauma. And then the third one, which is most of us, when we think of the word trauma, we're thinking of a person or a child or an adolescent experiencing or witnessing violence or abuse, whether it's emotional, physical, sexual. And that's what most of us think of when we hear that word. So that's part of why I just wanted to talk about that a little bit here, because all three of these different traumas can have a significant impact on an individual, and in particular on their brain. Like, that's what gets impacted the most actually by trauma. And so many of the children and families in our systems might have experienced at least one of these categories of trauma, and there are many individuals who have experienced two, if not all three, of these types of trauma, which is going to have an incredible impact on them for many years. So that's just a little bit of framing there. I do get asked a lot, what's more damaging to a developing fetus, drugs or alcohol? Clearly, we don't want our kids exposed to either. But the Institute on Medicine has reported that of all substances of abuse, alcohol is by far the most damaging. Now, that's super counterintuitive, right? You would think that meth or cocaine or heroin, marijuana, you would think that the illicit street drugs would be more damaging, but they're not. They are not good, though. They are also not recommended. This chart here is showing some of the differences that we can see between the various drugs and alcohol. And again, the drugs are going to have an impact, but not as severe and as strong as the alcohol, unfortunately. And so, one of the things that's hard, a lot of times we actually will have like confirmation that a child was exposed to meth or heroin or cocaine or marijuana even, but we often don't see alcohol listed under that. And there's a couple of reasons for that. One is that children who were exposed to alcohol alone don't have withdrawal symptoms at birth, like a lot of children who are exposed to drugs would have. And so they might see some signs and realize we should do some testing if they're seeing withdrawal symptoms, but they can't really test for alcohol because it doesn't stay in the system as long. I mean, they could, if the mom was seeming like she was using at that moment, but it doesn't stay in the system as long as drugs do. So there's usually not testing for that when we have an infant that's been born. So again, all of them are bad, but the alcohol causes the most damage. One of the things that we're seeing, though, is if we have a mom who was using drugs while she was pregnant, the likelihood that she was also using alcohol is pretty high. It's definitely not all people who use drugs were also using alcohol, but it's pretty common. And so a lot of times we have kids who are exposed to both drugs and alcohol. And then the impact can be even more, but still it's the alcohol is the one that causes the most severe of the challenges there. So in 1996, they made this a spectrum disorder. So you'll hear people say FASD, that means fetal alcohol spectrum disorder. So that is not a diagnosis. That's an overarching kind of umbrella term for several things under that spectrum. So the one thing that I'm always trying to get people, professionals, families, whoever it is, to understand is that FASDs are permanent disabilities. That does not mean there isn't hope. that our kids and adolescents and adults with this won't start to do better. It does not mean that. It just means it's something that is not going to go away. You do not outgrow it. It does change as people are growing and brains are developing and stuff like that, but it is a permanent thing. And the other thing that's really important to know is if we, whether we're adults or whether we're professionals or family members, can really look at these individuals from the perspective of brain damage or brain injury, it can help us to be much more supportive and to be offering the appropriate supports and interventions for them, as opposed to looking at it as a willful, disobedient kind of bad choices that they're making. That's how it often looks to us, because most people who have an FASD are super high functioning, come off as very, very competent people. But yet, because of some of these parts of their brain that were damaged, they end up having a lot of really challenging kind of behavioral things that play out from a symptomatic standpoint. So just reframing and looking at it as a brain injury will help us. These are the main diagnoses that are under the spectrum. So most of us have heard of fetal alcohol syndrome, FAS. That was kind of coined in 1973 is when they discovered that, that diagnosis, and when it went into our medical diagnostic manuals here. So for FAS, they have to have 3 facial features that they have to have for that. They have to have growth deficits below the 10th percentile, which they can outgrow as they're getting older, but in those early years, they're usually below the 10th percentile. And then they have to meet the cognitive profile. And so this is the picture of the face of FAS. So, and they actually have pictures that look at different ethnic groups as well, because we know that facial features can be different across different races. So, on here you can see the smooth philtrum is one of them. The philtrum is this bump or this ridge that we have between our nose and our upper lip. And so it's a smooth philtrum, a thin upper lip, and then short palpebral fissures, which means small eye openings. So again, children who have FAS are going to also have the microcephaly, the small brain, you know, the small head circumference under the 10th percentile. And the brain, our eyes are actually a part of our brain. And so if they have the smaller brain and have the microcephaly, their eye openings end up being smaller as well. You can't really tell most of these with the naked eye. There's a 5-point scale of how smooth the philtrum can be and of how thin the upper lip can be. And so they use computerized kind of stuff to do, you know, the diagnostics for this. They have some computerized tools that do the measuring. But also just, I have to note this too, that there can be people that have smooth philtrums or thin upper lips for other genetic reasons. But if they have all 3 of those facial features, that does mean it's fetal alcohol syndrome. So sometimes I volunteer in high schools in the health classes or, you know, child development classes and stuff, and I'll see the kids would sometimes start to look at each other and be like, oh, you've got a flat philtrum or a smooth philtrum, or, you know, that, and I'm like, no, it has nothing, that doesn't mean it just because they have a smooth philtrum. They'd have to have all 3 of those facial features for it to be this, because there's other genetics that will cause some of those things to happen. So partial fetal alcohol syndrome doesn't mean partially as challenging. Any of these 3 or 4 diagnoses you see on here can impact an individual in a severe or a mild way, or a whole bunch of ways in the middle. So there isn't any of these diagnoses that are easier or harder to have necessarily overall. So partial fetal alcohol syndrome just means they only have partial physical features. The kids and adults who have that do not have all of those facial features. But the facial features are the most prominent between the ages of 2 and 10, and some people can outgrow them as they get older too. So there's also that dynamic that plays into it. Now with FAS, you can get the diagnosis of fetal alcohol syndrome without having confirmation of alcohol exposure if they meet the cognitive profile. But the other ones, you have to have confirmation of alcohol exposure to get the diagnosis, which can be really complicated in many situations. The third one there, though, alcohol-related neurodevelopmental disorder, ARND. That replaced, in 1996, that replaced fetal alcohol effect. Some of you in past trainings might have heard of FAE. So nowadays it's ARND. And those are children and adults who received the brain injury of this, but did not receive any of the facial features. The facial features are kind of developed around days 19, 20, and 21 of gestation. So barely before they're even between 2 and 3 weeks of pregnancy is when those facial features are formed. But I know women, I used to work in an organization called Proof Alliance. Their former name was the Minnesota Organization on Fetal Alcohol Syndrome. And I worked there with biological families and adoptive, foster, and kinship families. And had a lot of biological families that I worked with, and many of them were, you know, awesome. They were all awesome, but some of them were families that had maybe unintentionally were like using alcohol before they knew that they were pregnant and their children were impacted, or they had received some misinformation that it's okay to use light or moderate levels of alcohol during pregnancy. But then some of the families were ones that had struggled with great, you know, huge addiction. And many of those different women were like, oh, I drank on those days, and their children didn't have the facial features. So they're not still sure exactly why some of the kids will get that face and some won't. But so the ARND is the invisible one on the spectrum. They don't have any of the physical features or the growth deficits, but they did receive the brain damage from the alcohol exposure. And so that's just important to know. There's all the time we have professionals screening this diagnosis out based on the face, all the time, still daily, all over our country. People, pediatricians, mental health staff, whoever it is, will say, okay, they will not even look at FAS if they don't see the face. And we've got to stop doing that, because that is really old information that's not accurate anymore. In the DSM-5, the manual that's used for coding mental health diagnoses, they actually put something in the back of the manual for further research, but some people are using this as a diagnostic code in certain areas of the country. I'm not sure about Oklahoma, but they put in their neurodevelopmental disorder associated with prenatal alcohol exposure, so ND-PAE. So that's another one that you might see sometimes. It's still not being used. It's being used more on the East Coast is where I've seen it used by a few people. But the top 3 ones are the ones that you're more than likely to see. So an important thing to know, though, is the face is quite rare. It's actually, I've got to update this, it's closer to 10%. Research is showing that like 7 to 10% of the kids and adults who are on the fetal alcohol spectrum have the facial features. So the vast majority don't have those facial features, even though that's what too many people are still using as kind of a screening kind of tool for this. So some of the factors that go into how the fetus could be impacted from the exposure, one is timing of exposure. So we know pregnancy is in 3 different trimesters, right? And it's dangerous and not safe to drink during any 3 of those trimesters. There's a lot of kind of misinformation out there that's okay during the 3rd trimester to use because the baby's fully formed and just getting bigger. But that's not the case. Actually, the 3rd trimester is when the intellectual disability aspect can kind of come into play. And so, so it's the 3rd trimester is when the brain folds are impacted and that kind of stuff, and they can end up with a lower IQ. Now, the vast majority of kids who have an FASD do not have IQs below 70. Definitely some of them do. I can't remember the percentages on that. But most of them have IQs above 70 and do not qualify for intellectual disabilities, although some do. The 1st trimester, though, is when most of the damage really happens. And so in particular to the prefrontal cortex, and some of those executive functioning skills are really hit hard. Also, though, like their sensory stuff and the brain stem that starts to build first, a lot of them end up having, a lot of the stuff with the fight, flight, or freeze kind of stuff and different things like that because of the brain stem kind of damage that they receive. So it can impact all aspects of their brain functioning. I worked with a family here in Minnesota, and the mom had been a college student at the University of Minnesota about 18 years ago and was partying like many do in college, and all of a sudden had a 10-week unplanned pregnancy. And she, make sure you're muted, everybody. Let me look here. Sounds like somebody might not be muted. Anyway, she went to the OBGYN when she figured out she had an unplanned pregnancy, and she said, she was very concerned because she had been partying a lot. And she told the doctor that, and they said it's okay. just stop drinking. You should be fine. She was concerned, went to a genetic doctor, had genetic testing done while pregnant. Everything looked good. Her son was born, had high APGAR scores, typical development those first several years, but kind of even as a toddler had really challenging, quirky behaviors. And before he was even in elementary school, they were having to get therapies and interventions and supports. Now, he was not diagnosed with fetal alcohol. He was misdiagnosed with a whole bunch of other things, including ADHD, which is one of the most common misdiagnoses. And she was telling all of these providers for years that she had used the first 10 weeks, and they all kept saying he doesn't have the face. And so when he was about 8 or 9, he had been in a residential treatment center for fire starting and dangerous behaviors. And they finally got to a provider who, when she said she drank the first 10 weeks, listened and sent her to an FASD diagnostic clinic. And he was then diagnosed. So that was good. The bummer is we just missed 8 or 9 years of the appropriate interventions that could have helped him to do much better and could have probably helped a lot with that family to not have had such stress over using strategies that don't work well with kids with fetal alcohol. So it's really important that we do try to catch this as early as possible. Resiliency of the fetus is another thing. So on this next slide, I'll flip back and forth to when they did research and looked at twins who had been exposed in utero, what they found was that identical twins had pretty similar impacts from the exposure, but fraternal twins had very different impact from that exposure. And so that kind of was showing the researchers that the resiliency and immune system and genetic, makeup has an impact on this as well. And so, that's a really important thing that we're aware of too. There's also research showing in utero that twins are both kind of fighting for the nutrients and that kind of stuff. So that's another reason why one is sometimes more impacted. But the metabolism and diet of the mother is a huge one that we don't think about it often enough. I will have people come up to me after trainings and say, when it was in person, this would happen at least, but they would say, I drank when I was pregnant with my kids and they're grown and they're adults and they're doing just fine. Or on the flip side, people will say, my mom drank when she was pregnant with me and I'm fine. And that's actually true for me. My mother back in the 60s drank when she was pregnant socially on the weekends. And they used to actually recommend to women when they were pregnant to use alcohol. And even when women in the 60s and before that, when they went into premature labor and went to the hospital, they would put them on an alcohol drip in an IV to stop the labor. And so, so there's a lot of, like different techniques. I have 2 families in Minnesota I've worked with that I know who figured out when their kids were almost 40 that that's why they had struggled their entire life, was that they had fetal alcohol from an IV drip in the hospital when they were pregnant. And so, so that's huge. But the metabolism and diet of the mother is a really big factor into the impact that these children can have. When those people would come up to me and say this stuff like my mom drank or I drank, I do think my mom's social drinking had an impact on me. I'm horrible at math. I changed my major in college 3 times to avoid more math classes. I struggle with the brain function of crossing the midline. So if I go to a step aerobics class, I can go up and down on the step. I can do that. I can do an A step and a B step, but then they go over the step and it gets really fancy and coordinated and my brain just freezes. Now, if I really wanted to, I could like practice and figure out how to do it. I can't figure out how to knit, crochet. Some of those things don't work well with me. Again, if I really liked doing crafty things, I could, work through it and figure out how to do it, but that's kind of not my jam. So I'm fine not doing it. So I think it did have an impact on me. And what I will say to those people is, hey, I'm really glad that everybody's doing okay. But who knows, you might have had 5 or 10 higher IQ points if that alcohol use hadn't have been there, or struggled a little bit less with attention. Like I totally have ADHD and struggle with attention and that kind of stuff. So it's we've got to just think a little bit more in depth about it. Now, am I mad at my mom? Absolutely not. It wasn't her fault. They didn't know. And even still, this happens on the daily to people who have unplanned pregnancies. 45% of pregnancies are unplanned in the United States. And so sometimes it happens very unintentionally. But the metabolism, so we could have two women who weigh the same and drink, and we give them each a glass of wine or a can of beer, and they drink it at the same speed and metabolize it differently and have different blood alcohol levels. And the same thing happens between the mom and the fetus, right? Because in that first trimester, the fetus doesn't even have fully developed internal organs that can metabolize at the same speed the mom can. So, so there's a lot of things that play into it. Nutrition is another one. And I forgot to say this, the most likely woman to have a child with an FASD looks like me. It is a white, middle-class, college-educated woman. There's a lot of misinformation out there that people assume this is something that just hits the Native American population or poverties of color or communities of color. It is not. What I'll tell you, though, is there's a lot of discrimination around this, and it would be much more likely that my child would be misdiagnosed with autism, ADHD, oppositional defiant disorder. I mean, the list can go on of what the misdiagnoses can be, but it's often that they're not asking the right questions. And honestly, even with a lot of communities of color or communities of different race or economic backgrounds, they're even still usually not asking the right questions, which is why this is so underdiagnosed, even though we expect that the rates are extremely high. And I'll talk about that in a second here. But so what we're seeing, though, is if the nutrition of the mother is good, and if she's having good nutrition, the impact to the fetus is not as severe if there's poor nutrition. And so a lot of times, some of the kind of lifestyle plays into that too. So if we have people who are struggling with really at-risk lifestyles and addiction, sometimes those children might have a higher level of impact from the exposure than somebody who's struggling with addiction, who also is, other than their addiction, maybe living a somewhat healthy lifestyle with good nutrition, then the impact isn't quite as severe. And then also we also know generational trauma plays into stuff as well too, and that, that can impact things too. But the research on the nutrition is even showing that if the woman's iron levels are high and she's not anemic, that the damage to the fetus is not as severe. So they still don't know a lot of the information on this. They're still trying to do more research. It's a very under-researched diagnosis. Unfortunately, there's definitely research going on about it, but not nearly enough. And then the other big factor that plays into the impact to the fetus is the blood alcohol concentration of the mother. There are still OBGYNs and medical people out there who say it's okay to drink lightly during pregnancy. I and just about anybody who has worked in the FASD field are going to tell you that that is not true. There is no safe amount of alcohol during pregnancy. And some of the research that's sometimes cited is very faulty. It was from the Netherlands, I think. I can't remember, somewhere over in Europe. And it looked at only at the first 7 years of the children's life with the light drinking. And I'll talk about in a few minutes here why we start to see a lot of the things kind of break down after age 7. But yes, definitely the higher level of drinking and binge drinking is much more likely to have more obvious impact to the child. Prevalence. So in 2018, some research came out showing that 1 out of 20 children have an FASD. That is twice the rates of autism. And they still think that this is way lower than what it's supposed to be, that it's probably even higher than that. It's a really hard one to diagnose and to get the right information on. So what they did was they went to 4 communities around the United States. They went to a middle-sized Midwestern town. They went to a small mountain town, they went to an inner city diverse area, and they went to a suburban community. And they studied over 6,000 first graders. And 1 out of 20 of them met all the criteria for this diagnosis and should have been diagnosed with it, but only 2 of them were. Only 2 of 6,000 were diagnosed with it, and it should have been 1 out of 20 of them. So what is that, 300 or something like that should have had the diagnosis. And so I think it's our #1 public health epidemic. I think it's leading to high rates of addiction because it's a really common thing, because impulse control is one of the kind of hallmark areas of the brain that is damaged. And so very high amounts of people with an FASD end up struggling with addiction. But it's also leading to, I think it's leading to all of the really high rates of mental illness that we're seeing, because it's commonly it's that it's misdiagnosed, but a lot of times it's a co-occurring diagnosis as well, leading to high rates of teenage pregnancy, homelessness. I mean, if you just look at all of our public health kind of things, I think fetal alcohol plays into just about every one of them. I'm not saying every person who's homeless has an FASD, or every teenager who gets pregnant has an FASD, or anybody who struggles with addiction, but I think that the rates are probably pretty high. So some of the red flags for this. So again, I mostly now work with adoptive, foster, and kinship, you know, in the child welfare system, but we are seeing that in adoptive and foster and kinship families, really high rates of it. The National Organization on Fetal Alcohol Syndrome estimates that about 70 to 80% of children who go into foster care were prenatally exposed. And we're seeing a huge rates of it in a lot of international adoptions: Russia, Kazakhstan, Ukraine, Korea, a lot of African adoptions, even South American. We're seeing it just about, you know, in all of the countries. Two countries we don't see it often in for international adoptions is China and India, but we're seeing it in many of the others. Korea actually has the highest rate of alcohol consumption per capita in the world. And so, you know, it's just, it's hitting those families at high rates. If we know there's chemical dependency issues for, you know, for a family, that would be a red flag, or even for the adolescent, that's a red flag to look into this. There have been different projects around the country. There was one here in Minneapolis years ago where every child that came into the juvenile justice system for a year or two, they actually screened for this. And I got to look that up. I can't remember the rates of how many of them ended up being diagnosed with an FASD, but it was very high. And that's actually how Minnesota is kind of the leading state in FASD in our country. And Proof Alliance was started by our first lady from back in the early 90s, I think is when she was the first lady. Her husband was the governor of Minnesota, Arnie Carlson and Susan Carlson. And she was a judge in Hennepin County in the juvenile court system, and she was seeing it, and was able to get the governor, her husband, to kind of start up a task force and even earmark money in the legislature every year for support and awareness around this. So we're seeing high rates of it. But if we have a child too, though, who has some of the classic ADHD symptoms, the hyperactive, inattentive, impulsive, that's a red flag. It's such a common misdiagnosis. One of the lead researchers a couple of years ago, I was talking with him about the similarities and differences, and he said two of the things they see in being more common for kids with an FASD is, one, they are more likely to be verbally and or physically explosive or aggressive. And number two, they're more consistent rule breakers. So that doesn't mean a child or adolescent with just straight ADHD won't struggle with those, but it's much more common for our population. But another thing is, if we have two kids or adolescents, whatever age they are, and we have one here who has ADHD and one here who has an FASD, we know both of them struggle to focus and pay attention, right? So maybe we do an activity with them, a little sensory thing, before we have them sit down to work on a learning assignment or something like that. And so we have them get their energy out, do a sensory thing. They both are able to sit for maybe 10 or 15 minutes and focus on something we're trying to get them to comprehend and understand. And they get it, and they've got it. It seems like they've kind of mastered it. And then 30 minutes later, an hour later, a day later, we could ask them a question about that. And most children or adolescents who just have regular ADHD will have retained that info and can use it and tell you what's up. Now, a kid with an FASD very often is just kind of looking at you like, what are you talking about? And so, and you're like, are you kidding me? Like, you totally had this 30 minutes ago, and now it's like you've never talked about it. So that can be really common. So that's a little bit of the way to try to tease out some of the differences there.
Hey, Barb, we had a question of,
okay,
if you could give some examples of some of the sensory activities.
Absolutely. And I'm probably going to be talking a little bit about that in part 2 today. But the sensory processing disorders are super common with kids who have an FASD, because our senses of taste, smelling, hearing, to all of that is a part of our brain and our central nervous system. And so just doing stuff like having them jump on a mini trampoline or a trampoline, having them chew on hard foods or chewy foods, you know, getting some of the oral sensory stuff going, letting them use noise canceling headphones if they're overly reactive to sounds, you know, just getting their body kind of moving so that their sensory stuff isn't so off kilter, because usually it's quite off kilter. And so the most effective intervention for fetal alcohol is occupational therapy with a sensory integration focus to it. And so talk therapies are often not very effective with this population, especially in childhood and adolescence, although there's still value in much of that. So we won't have time to probably get super in depth on some of that stuff, but there's a whole list of different sensory stuff. I would recommend doing a Google search on sensory processing disorders or sensory diet strategies. Sensory diet is what an OT then would give a family after they do an evaluation. They give you a sensory diet of what would help this child to calm down and regulate, and what would help them to also activate, because some of our kids are underactive and kind of internalize and go inward. Most of the kids with fetal alcohol go outward and explosive or things like that, but sometimes we need both. So that's a couple of ideas. These two bottom things though here are super common if with kids with fetal alcohol. If we have a child or an adolescent or even an adult who keeps making the same mistakes over and over and not learning from a consequence, that's a neurodisconnect. It is not neurotypical to keep doing the same thing that's getting you in trouble and to not learn from the consequence. Doesn't always mean fetal alcohol, but it's definitely something that should be looked at for that if you have an individual who is struggling with that. It's very, very common. It's almost across the board, literally, for fetal alcohol is making the same mistakes all the time. Multiple diagnoses, especially a lot of mental health diagnoses, they sometimes just kind of pile them on. I used to sit and try to fight a lot of those diagnoses and say, no, it's fetal alcohol. I know it looks like ADHD or reactive attachment disorder or whatever it is. And eventually I was like, okay, why don't you add that to the list? It might open up a new door for services that we couldn't qualify for. But there's 428 common co-occurring diagnoses with fetal alcohol. A lot of them are medical. A lot of our kids, especially as they're getting older, some of them are born and have some medical complexities. But sometimes they might just have some hearing or vision or different things like that. As a lot of them are hitting adolescence, we're seeing a lot of rheumatoid issues is really common with this population and other stuff. So that's common. If we have a child or adolescent who has some of those extreme behaviors of emotional dysregulation, right? The verbal explosiveness, physical explosiveness. Not all kids by any means are aggressive. That's not at all what I'm saying, but a good chunk of our kids are, unfortunately. So that's a red flag. Sleeping and eating issues. So even when I worked, that family I was mentioning earlier where the mom was a college student and that kind of stuff, you know, wonderful family. She got married, had 2 other children who were not prenatally exposed. They have wonderful parenting skills, financially stable. The only trauma her son experienced was 10 weeks in utero exposure. And he has sleeping and eating issues like we see being common with people that have had food neglect or, you know, food insecurity or trauma histories and stuff. So sleeping and eating issues are really common. Average IQs or even a high IQ, but functioning way lower than what you would expect based on their IQ. That is a really common kind of thing. I'll go to IEP meetings often. Schools hire me sometimes to do that, or sometimes families, I go with them. And we'll be doing the 3-year evaluation report, and the school psychologist will be like, oh, well, they must have been really off this day because their IQ is 97, but their working memory was 40, whatever, or, you know, all these things. And I'm like, oh no, that's not, they weren't off. That's probably their norm. That's typical. That's why they have these huge strengths, things that they're really good at, and these huge deficits and things they really struggle with, which is what, you know, averages out where their IQ is. And that's a really common thing. So, we're often expecting them to do stuff based on their IQ and the fact that they appear so typical in conversational skills, but that their brains aren't able to do. So that's a really hard one. And then these two bottom things, if we have a child or adolescent who can tell you what the rules are, but can't follow them, or these are the ones who tell you what the rule is and turn around and break it, and then they can't figure out why they're in trouble. That's another neuro disconnect that is not neurotypical, and so common for our kids. One of the things, though, that I always like to talk about is that a lot of kids who have an FASD might have significant struggles early on in life, but many of them, maybe it's just some quirky, somewhat challenging behaviors, nothing off the rails big time. But a lot of times what we see is they're doing somewhat okay in preschool and kindergarten through 3rd grade. And the reason for that is kids with an FASD are very, very concrete thinkers. They don't do well with abstract concepts very much. And our curriculum, preschool and K-12, follows typical adolescent child brain development, right? And so we know that a kindergartner's brain's kind of concrete. And so that's how the curriculum is developed around them. You're learning your ABCs, your 1, 2, 3s. We're not expecting them to use a lot of that deep problem solving kind of skill stuff in their brains. And so as they're getting into 4th grade, though, and each year after that, the curriculum becomes more abstract, and we're expecting kids to use their problem solving skills in the prefrontal cortex. And that doesn't work very well for our kids. So they're sitting there and they're having to do word problems, which I tell you what, word problems still make me want to vomit. I hate word problems, right? And then you're getting into algebra, and that's like just makes no sense, putting numbers and letters together. Who thought of that idea, right? So it's, you know, they're sitting there in 4th, 5th, 6th grade, and it hits them at a different age, just depending on the way their brain was impacted. They're starting to have huge anxiety at school all of a sudden because they're not comprehending or understanding stuff. Now, obviously, this doesn't fit the low functioning, our kids who are in that low functioning category, but it's really common for the rest of our kids. And so now their anxiety is increasing. It's also when we start to see a lot of them becoming socially isolated. And so what happens is that when their social skills are, well, actually their overall kind of functioning is usually at about half of their age. And so when you're 5 or 6 in kindergarten and 1st grade, everybody's kind of acting immature, right? But by the time you're 10 or 12, if you're acting half of your age, and your social skills lag behind your same age peers in you, they kind of start pulling away. So a lot of our kids in the early years have friendships and relationships and are invited to sleepovers or birthday parties. That picture there is the last birthday party my daughter was ever invited to because she broke a bowling ball at it. I'm pretty sure freaked that mom out big time. I had to pay $75 for that ball. And she was never invited to a party again. And I'm pretty sure the rumors went through the school really fast after that happened. And so, they start to become socially isolated and kind of lonely. And so here we have this perfect windstorm of these kids who are not comprehending stuff and are starting to feel dumb. This is what they would say. They're not dumb, but they start to feel like they are. They're starting to feel socially isolated and lonely and possibly bullied. And because that's when that really ramps up in schools, is 4th through 6th grade. And then also their bodies are starting that fun pre-hormonal changes of puberty. And so it's this perfect kind of trifecta, I call it, at the end of elementary, beginning of middle school. And so some of them just start to go like this slowly. And for some, it's a steep just drop off the edge of the cliff. And so what we've got to do is we've got to wrap around, right? And we've got wraparound supports in Oklahoma. We've got to wrap around when we see these things start. We've got to wrap around those kids as much as we can, get the schools to do the same thing, and the families as well. Like all kind of people that are supporting this young person need to be doing that, and make the changes necessary to whatever the accommodations that we need to do, the modifications to the curriculum, whatever it is. Because if we don't, here's what happens. Now, all of a sudden, we've got an adolescent who has significant self-esteem harms, who starts with the self-harming behavior, the suicidal ideation, school refusal, right? And you know what? If you're sitting there not understanding anything, like I wanted to exit out of every math class I was in after 5th grade. I just hated them, right? And I think I understood it at a higher level than a lot of kids who are impacted with an FASD. So I mean, I never did just bolt. Well, I'm sure I had a lot of bathroom passes. I'm sure that was when I had to go to the bathroom every day. But who wants to sit in something they don't understand and it makes you feel dumb? It's not fun. So of course they're going to start having more behaviors than in the school system, and then they're going to be getting into more trouble. And then they're also, if they're not, they're bottling it up all day and getting home and exploding. It's called the delayed effect. I don't know if anybody's read much about the delayed effect. That's the dynamic of a lot of kids with special needs who maybe are able to hold it together during the school day, but they get home and they blow. And that would be, my daughter was like that her whole life. And it's like use the Coke bottle analogy. It's they're riding the bus to school and it's a couple of shakes to the Coke can, if they're a Coke can or Pepsi can, whatever, right? And it's really loud and chaotic on the bus. And then they get to school and they're walking in the doors and somebody bumps into them. That's another shake. And then they're in the hallway and somebody calls them a name and that's another shake. And then they're in class and they don't comprehend. And so all day long it's being shaken. And most of us are going to express our frustrations with the place we feel the most safe and the most supported and the most loved, right? And that's home. So that's why there's this big blow up then. So as much as we can do to help them not go down that hill when we start to see any of those things, and it's going to hit them at different stages because their brains are all different, the better. Okay, so a couple of these things I got to skip. One thing to know is if we have a child who has, if we have kids who are under 5, who even if we just suspect they were exposed prenatally, choline is a natural thing that is in a lot of healthy protein-based foods. It's also an over-the-counter supplement you can get. They put it in most prenatal vitamins and baby formulas now because they know it's important for neurocognitive skills and in particular memory kind of stuff. But they've showed in research that was just published in the last year, that was a 10-year longitudinal study, that choline supplements actually improve some of the neurocognitive damage that the kids received. It was most effective between the ages of 2 and 3, but it also was at 4 and 5. They don't think it is after age 5 very helpful, but it doesn't hurt, right? So that's an important thing to kind of be aware of. We don't have a lot of time to get into diagnostics. I did list a few of the diagnostic clinics that I could find in Oklahoma. I've got 2 slides worth of them here, and I have turned these handouts in if anybody wants them, but or take a picture of your screen right now too. Anyways, these are some of the clinics that specialize in it. If anybody knows of others, this is the second list. If anybody knows of others, you can also put them in the chat box and let people know. But the diagnostics are complicated. It's a medical person who does the facial feature measuring and does the maternal history of alcohol, which can be really hard to get no matter if it's biological or adoptive foster kinship. But and then the neuropsychologist does neuropsych testing, and those 2 pieces together are what determine if they are diagnosed with this or not. Quite often, a lot of families I've worked with, they really feel in their gut like this is what their child has, but they can't get the diagnosis because they can't get confirmation of that exposure. And it can't just be verbal confirmation. Most diagnostic clinics will not just take verbal confirmation. And so I will just tell those families all the time that what you have to do, just use the strategies, just use it in your head that this is probably what they have. Try to tell their school team, this is what we suspect. Here's why we can't get the diagnosis at this point. Hopefully someday they have better diagnostics. They are doing epigenetic testing and we'll hope to have a genetic test someday, but I think that's years away still. But the diagnosis is important because what happens is when these kids are undiagnosed, they don't get the right supports and interventions. And then that is what leads to more frustration in the family. And it also is what leads to significant self-esteem issues for the child or adolescent. And so, because it feels like crap to always be in trouble and to be ticking everybody off, whether it's at school or at home, right? It does not feel good. Nobody likes to be in trouble. And even though it looks like they maybe do because they're trying to do it intentionally is how it can look, that's not how it is. And so, so this diagnosis can really explain a lot, not only to the family, the school, but also to the individual. And having somebody who appropriately helps them go through the stages of anger and grief and that kind of stuff. Honestly, most of the time when it's children and adolescents and even young adults, when they find out about this, especially in adolescence and adulthood, it's a relief is what I have heard from the majority of people. Now, yeah, they might be mad for a little bit or have some different emotions, but it's usually a relief because they're like, I'm not just dumb, is what I've heard so many of them say. And so there's a reason why they keep making the same mistakes over and over. Now, it doesn't mean it's an excuse, but it does explain why some things keep happening. Not going to get into all of those. How to ask why if we do have a family that we're working with where it's the biological parent, instead of just saying, did you use alcohol when you were pregnant? Because most people are going to feel uncomfortable and blamed and don't want to, just going to say no, right? But if we ask it differently, and if we say, is there any way before you knew you were pregnant that you could have been using alcohol? And then if you just also add this, because it's happened to a lot of my friends and family, and I'm just trying to figure out how we can find the best supports for this child, for your child or this child or whatever. I've had adoptive and foster families ask that to birth parents that they've been connected with, or I've also had lots of professionals asking it that way, and you're much more likely to get the accurate information if you ask that way instead of just the open-ended, did you use alcohol or not when you were pregnant? So there's a lot of strengths that our kids have and adults with this. Most of them are super fun, kind, caring, great senses of humor, but that's when their brains aren't on fire, and their brains are on fire a lot. And because of that, we often have really challenging behaviors with this population. But a common strength is being good with younger children. That's something we should utilize, whether it's at school, whether it's in the home, whether it's in community settings. Have them doing stuff, have them doing, service learning, intergenerational teaching with the younger kids in their school, but have them helping with babysitting. But if they have impulse control issues, which the majority of them do, they should not be around younger children without high levels of supervision. It's just too dangerous, and it's not fair to them because we've just had way too many issues with that. Now, I'm not able to sit and go over every strength in depth because we got to talk about the hard things. And so I'm going to jump here into some of the symptoms and the hard things here. And I'm starting to go fast because we're running out of time. I never have enough time, you guys. Good thing there's not a closed captioner, but I'm sorry to the interpreters. Okay, so an FASD developmental timeline. So this is a common kind of profile that we will see of scattered development for an adolescent who's 18 and about to graduate high school. At 18, many of them have the expressive language skills of a 20-year-old. This is one of the reasons why, whether you are supporting them in wraparound services or family therapy or whatever it is that your role is, or if you're a parent, this is why we're all so confused, because they seem so incredibly smart and competent, and they are smart, but there's all these other things in their brains that don't work well, but their expressive language skills are generally a strength. But yet at 18, many of them have the comprehension and emotional maturity of a 6-year-old, the time and money concepts of an 8-year-old, social skills are at about 7, and living skills are at about 11. So if you take this, we call this scattered development, right? It's not that they're immature, it's something called dysmaturity. It means that their developmental maturity does not match their chronological birth age. And so we often say go with brain age, not birth age. And so as I was saying earlier, we recommend taking an individual's age and cutting it in half. And that's probably closer where they might be functioning at, although it's all over the map. I mean, that's one of the things that's really common. Like one moment, my 21-year-old daughter might be acting like a 21-year-old, and then 20 minutes later, I've got a 4-year-old on my hands. And then another 20 minutes, she's acting like a 13-year-old, right? So, and that's exhausting. Let me just say that's exhausting, whether you're teaching the child in a school setting or working with them in a therapeutic setting or parenting them, whatever it is. It's exhausting to be having to, kind of switch your style and your approach all that much. So if you look at this developmental mixture, though, somebody at 18 who's supposed to be graduating from high school, if we're going to expect them to go off into the real world and go to college or community college or vocational trade school, or even just get a job without a lot of support, are they going to be successful without a lot of support around them? Probably not, if this is their developmental kind of scatteredness. And so we've got to be looking at that and figuring out kind of what we need to do to support them in those adult years. and kind of look at things a little bit differently. And again, cut their age in half. And there's a lot of hope with this, you guys. People often tell me they don't like this diagnosis because they feel like it's hopeless and that there's nothing you can do. Oh, there's a lot we can do. And what I'm seeing is a lot of our kids and adults with this in their 30s start to do better. Now, I know if you're somebody who's parenting a kid with this or working with a kid who's 5 or even 10, you're like, what, 20 more years? I know that sounds exhausting and daunting, but a lot of them can do better, but they need a high level of supports in those young adult years usually to get to that point. So I'm going to kind of stop here, and we'll pick up in whatever 30 minutes or so with part 2.